Thank you very much. I would like to thank the organizers for giving me this podium, and thank you, Dr. Meenal, and the chairpersons and all the entire team, DRS. Yes, three wise women. Interesting story. And this is not getting connected? Yeah. So a disclaimer, this is not an animation movie and this is not a cartoon film either. But yes, three wise women talking, debating as to if you want to choose only one drug for type 2 diabetes management, what it should be. And I'll be speaking on the GIP-GLP1 receptor agonist. So it's an interesting topic to choose on, diabetes being such an upcoming epidemic. If we want to choose one drug, how should we go ahead with it? So if we look into it, we know that type 2 diabetes is a progressive disorder, and much before the diagnosis of the disorder, we have already begun on our cascade of micro as well as the macrovascular complications. So that is something which makes it even more difficult to understand and to control, because we know that the complications have begun to occur already. The other important thing, we know that treating early treats the long-term complications. We know that a suboptimal glycemic control in the first year of diagnosis, if we keep a glycemic control more than 6.5 in the first year of diagnosis, we have a much higher risk of micro as well as macrovascular complications in the future. So this we know very well as the metabolic memory and the hyperglycemic legacy which is there, which persists. And so what is our target? Our target is first to diagnose it as early as we can, and number two, as soon as we diagnose, we have to control it well. We have literature which states that if we control it well, we can reduce the rates of myocardial infarction by 20% risk reduction in future life, as well as a 19% risk reduction of all-cause mortality. And the other way around, if it is not controlled, then we have a much higher risk. So intensive treatment in the early phase becomes important. This is something that we have gone to realize from the past few years. And then we talk about what can we do for that. So incretin-based therapy, why should we say that incretin-based therapy should be a treatment of choice for us when it comes to this, as the question which was that which is the best drug you can think of? So when we look into that, what is the pathophysiology? This we have seen so many times, that there is an impaired insulin secretion, impaired glucagon, increased glucagon secretion. So this is the pancreatic point of view from which we have which contributes to the hyperglycemia. There's an increased hepatic glucose production, which is very important, mainly accounting for the basal hyperglycemia that remains, an impaired appetite regulation, decreased glucose uptake, increased lipolysis, decreased incretin effect, and increased glucose reabsorption at the level of the kidneys. So we have so many drugs which act on some particular of these areas, but then we have some group of drugs which act on multiple of these areas, and of which we have these group of the GLP-1 receptor agonists. So this is what I have to say, that when we have to manage in a holistic and a multifactorial approach, then these drugs are a very good agents which have impact not only on the increasing the insulin secretion, they lead to a reduction in the glucagon secretion. Also, the hepatic glucose output also, they have an impact on delaying the gastric emptying, and hence they prevent the immediate hyperglycemia which occurs like post meals, postprandial rather I can say. The impact on satiety and the hypothalamic centers, leading to increased satiety, so less food intake, less cravings is what is important, beneficial impacts on the cardiovascular system, and low risk of hypoglycemia. So a multi-factorial approach with a multi-pronged impact, which the incretin receptor analogs that we have. So now if we look into this, we have these DPP-4 inhibitors. We know that they are relatively weaker when we talk about efficacy wise with regard to the incretin receptor analogs. So now we have a situation where we have one GLP-1 receptor agonist, which Dr. Lily will be throwing much more light on. But we have a combination of GLP-1 receptor as well as the GIP receptor analogs. Now, why do we prefer the GLP-1 to GIP-1 receptor analogs? Why do I prefer that? I will be discussing in the next few slides. So, looking into the dual GLP-1 and the glucose-dependent insulinotropic polypeptide, that is the GIP receptor agonist, let's see how they work. So if we look into the proposed role of how they work, we see that the GLP-1 receptor activities, mainly when it comes to the CNS, is a reduced food intake, an increased satiety, increased nausea. And pancreas, it leads to an increased insulin secretion and reduced glucagon secretion. Stomach, there's a delayed gastric emptying. Whereas when we talk about the GIP-1 activity on the CNS, again there's a reduced food intake, some decreased nausea can occur, is there usually as against the GLP-1, which leads to increase in nausea. And the pancreas, what is interesting to know is there's an increased insulin secretion like the GLP-1 activity, but there is an increased glucagon in a glucose dependent way. So what do we mean by that? What we mean is that when there is hyperglycemia, the glucagon is suppressed, but when the same patient tends to go into hypoglycemia, the glucagon may increase and prevent the hypoglycemia occurring. So it's a glucose dependent mechanism which occurs specifically with the GIP activity. The GIP activity also has a significant impact on the adipose tissue. So adipose tissue, by increasing the lipoprotein lipase activity, it leads to an improved metabolism of the lipids, leading to and it also has an impact on insulin sensitivity being increased lipid buffering capacity, increased blood flow to the adipose tissue, increased storage capacity, and reduced pro-inflammatory immune cell infiltration. So a significant impact on the adipose tissue and glucose-dependent impact on the glucagon and a good CNS involvement are the additional benefits with the GIP. So looking into the GIP action on the adipose tissue, a high-fat diet leads to an increase in the K cells, which the K cells are the K and the L cells are the one which lead to the incretin release in our body, and the K cells lead to a release in the GIP secretion. So when the GIP is secreted in excess, when the glucose levels are low, this, as I said, the GIP promotes the glucagon secretion and from the alpha cells, preventing the patient from going into hypoglycemic episode. As oppositely, when the patient is in hyperglycemia, then it inhibits the glucagon secretion. And when there's a hyperglycemia, the insulin secretion is the one which is mainly occurring. So it has this impact depending on the glucose levels. And then it has an increased lipoprotein lipase activity. So what does lipoprotein lipase do? It helps in the chylomicrons. The triglyceride chylomicrons are then broken up into free fatty acids and glycerol, which are then taken up for energy by the muscle cells and the fat cells. So it puts into use the fat where it should be used and not just for the storage purpose. So GIP has an definite impact on the adipose tissue as well. So when we talk about this dual antagonist, we know what we're talking about is tirzepatide. And the tirzepatide activates the GLP-1 and the GIP receptor. It's the structure which we have in market the structure is based on the native sequence. It has a very good activity on the GIP receptor. It has a relatively lower activity on the GLP-1 receptor. The half-life being around 5 days, so enabling a once-a-week dosage, and there is no dosage adjustment required with renal or hepatic impairment. So having looked into the physiology of how the GLP-1 GIP receptor agonist acts on our in our body, and especially in cases of type 2 diabetes, let's look into its impact on the obesity. Now, it's very interesting to know that tirzepatide addresses the biological adaptations of obesity. So what do we understand by the biological adaptations of obesity is that when there is a person is obese, he develops a lot of there's a cascade of events which occur as a biological adaptations in the form of some hormonal changes occur. There's an increase in appetite. There are so many changes in the metabolism so as to preventing the person from losing weight. So and a lot of cravings and all that come up, and all these prevent the weight loss which a person would be trying to do. So the biological adaptations also, these GLP-1 GIP receptor agonists they have an impact on that, and they reduce the appetite and the caloric intake by increasing the feeling of satiety and reducing the hunger pangs which the patient would be having. Also, very importantly, reducing the intensity of cravings and preferences for high sugar foods and high fat foods. This becomes very important. The patient does not like so much as he used to like the high sugar and the high fat foods, and this becomes important in controlling. Then the GIP receptor agonism in adipocytes further modulates the lipid uptake and the regulates the glucose uptake, improving insulin sensitivity and increasing lipolysis by binding to the human adipocytes and activating the GIP receptors. So this combination has been found to have a significant weight loss, and out of which there's a major fat mass loss rather than a lean muscle mass loss. Now, looking into some literature as to how these are working, and some evidence for what is the evidence that we have with tirzepatide, and we know that for weight management, large number of clinical trials have been done. Surmount 1 was a trial which was done for weight management of tirzepatide versus placebo, and that shows a good weight loss. We'll be discussing in the next few slides. The second, Surmount 2, was weight management in diabetic patients. 3 was after an intensive lifestyle program. Then one arm was continued on tirzepatide, and the second was with placebo. And 4 was weight reduction maintenance, and Surmount 5 was a very interesting trial which most people are talking about these days, is the maximum tolerated dose of semaglutide one arm and tirzepatide second arm. And what this evidence show is that the weight reduction with tirzepatide was in the Surmount 1 trial was 16% average weight reduction with 5 mg of tirzepatide at 72 weeks, and with 15 mg we get a weight loss of 22.5%, which is very significant with any molecule as such. So patients with obesity on tirzepatide experienced an improved body composition. Yes, this is just one more minute. There was a greater fat mass loss than the lean body mass loss, and there was a better waist circumference reduction as well. So that then goes on to a reduction in the visceral fat as well. That becomes very important with regard to the organ function and dysfunction. What about the HbA1c reduction? Was very significantly better, and even the cardiometabolic parameters were shown to have improvement in the form of systolic blood pressure, diastolic blood pressure, triglycerides, and LDL reduction with an increase in HDL cholesterol. The Surmount 5, which looked into tirzepatide versus semaglutide, because the next speaker will be talking about the GLP-1 receptor agonists themselves, why they alone are not sufficient. So it has been found, the data clearly states that where the maximum tolerated dose of semaglutide showed a 15.4% reduction, the tirzepatide showed a 21.6% of reduction of body weight. And the larger number of patients had a weight reduction at 72 weeks. So what about the adverse reactions? Now it has to be considered whenever you talk about the good effects of a drug. Then what are the side effects? Yes, we do have some gastrointestinal side effects, being the most common: nausea, diarrhea, constipation, dyspepsia. They were mostly comparable. When in Surmount 5 we saw that they were comparable in both the arms. The injection site reaction was more with the tirzepatide group as compared to the semaglutide in the Surmount 5. Otherwise, as like all GLP-1 receptor analogs, the nausea, vomiting, diarrhea were the most common side effects. So summarizing, tirzepatide significantly reduced body weight by an average of 16% with 5 mg, and then when we go to a higher dose of 15 mg, 22.5%. The superior weight reduction compared to semaglutide, 61.6% with tirzepatide versus 15.4% of semaglutide. Improvement of key cardiometabolic parameters, and most importantly the adverse reactions being gastrointestinal gastrointestinal, which could be controlled by a proper counseling to the patients. So let's hope the three wise women align themselves to a single panel conclusion. Thank you very much. This is my institute where I'm working since past 30 years, my alma mater, Sorry Mansingh Hospital. Thank you very much for your patient listening.